So this is a frontal chest radiograph of a skeletally mature patient. And I can see an endotracheal tube in situ. There are multiple soft tissue density nodules which are randomly distributed in both lung fields, in the upper as well as in the middle and lower zones. And most of these nodules are cavitating.
Okay.
I cannot see some opacification is also noted in the left lower zone. I cannot see any.
I'm not sure. Because the diaphragm is clear here.
Yes, yes, and the CP angles are also clear.
The stripe is clear, so there's at least no major consolidation there, right?
Yep. There is no pleural effusion and no retrocardiac density. The diaphragmatic contours appear normal. And the visualized bones, these appear unremarkable to me.
Okay, great.
So based on these findings, I would like to give my differential. So my first differential.
Before you give differential, just sum up your finding.
So there are multiple cavitating nodules in the bilateral lungs.
Okay.
More so in the lower zones.
Okay. All right. So what's your differential diagnosis for such cavitating nodules?
Okay. So my first differential would be a metastatic disease process, likely from a squamous cell carcinoma, because I can see an endotracheal tube. So the second.
So what could be the source of this patient?
So it would be a squamous cell carcinoma involving the head and neck pathology, the laryngeal pathology.
Carcinoma, excellent. Any other differential diagnosis?
Yeah, well, I would like to keep Wegener granulomatosis as my second diagnosis because it can also.
Say it again.
Wegener's granulomatosis.
Wegener, excellent. Or yeah, you mean like autoimmune disorders like Wegener or rheumatoid nodules?
Yes, sir.
Okay, anything else? Third differential? Would you consider infection?
Yes, sir. I would. The infection will be right third diagnosis.
Such as?
Any fungal infection.
Okay, so the patient, you have to ask me about the immune status of the patient, right?
Yes, sir.
And any other infection can present with cavitary nodules and the patient will be septic?
Yes, sir. Yes, sir. Septic emboli.
Excellent. Septic emboli. So this is the top differential diagnosis for cavitary lung nodes. Excellent. So this is the CT scan of this patient. So as you clearly mentioned, there is a mass within the larynx. And that's why the patient underwent tracheostomy. And you see, as you mentioned, you can tell us more about this nodus. So read the demonstration of cavitary lung nodes like this.
Yes.
Now, so now very few of the tumors can cavitate. Top of them will be the squamous cell tumors, as you mentioned, either from the lung or the head or neck, and or from the uterine cervix. And uniquely, these nodules, they tend to cavitate even if the nodules are small. Okay? So you see, the nodules are small, but they are cavitating. So it's not the outgrowth of the blood flow, whatever. It's like it's innate thing within these nodules. So number one, the other tumors that tend to cavitate is metastasis from colon cancer sometimes. Particularly those underwent treatment. And rarely you see cavitary nodules or metastasis from sarcomas. Okay. The other differential that you mentioned is Wegener or the GPA or the rheumatoid nodes. And in case of rheumatoid nodes, usually they accompany the presence of skin nodules or the rheumatoid skin nodules. The other differential will be infection. On top of that will be the septic emboli. And in case the patient is, but the septic emboli, the patient will be really sick. I mean, he's septic. And fungal pneumonia, and then the patient should be usually immunocompromised. Okay? So the diagnosis is capillary metastasis from laryngeal squamous cell carcinoma, as you did very well. So the differential diagnosis I mentioned: infectious process, inflammatory process like rheumatoid nodules, and vascular conditions like Wegener granulomatosis, or now we call it granulomatosis with pulmonary. So this is a case of septic emboli, multiple like nodules. They may, up to 50%, they cavitate. The patient was septic. And this is the case of somebody with rhinitis, multiple lung nodules. Some of them are cavitating, and the patient has renal problems. So this was a case of Wegener granulomatosis. I will tell you, this patient had right nominectomy. Okay?
Okay.
So is this appearance normal or abnormal?
This is certainly an abnormal appearance, not for the right side, but I'm concerned for the left side. As you have mentioned that there is right side pneumonectomy, I would be expecting that the volume would be low, but on the left side there is significant specification. Bilateral CP angles are blunted.
So let's focus on the right hemithorax. I mean, in the left, yeah, there's some element of consolidation, whatever, in the left hilar area and the left thoracic area. But my question is about the right thoracotomy space. Is it normal or abnormal?
No, it does not look normal.
Why?
Although the volume as expected would be low, however, there is a significant mediastinal shift also, mediastinal widening also seen. And
so you're saying it's abnormal, right?
Yes.
Because
there is significant mediastinal widening, specifically in the upper and middle part of the mediastinum. There is blunting of the
this is not the main reason why the right hemithorax is abnormal.
Yes, I'm also narrating the other abnormalities which I have seen in this image. There is a significant blunting of the CP angle, and the patient is lying in supine position. There is upward tracking of upward tracking of probably the pleural effusion along the thoracic cage.
Yeah, that's true. But if you have like nominectomy, where do you expect the mediastinum to go? So this is the mediastinum. Where do you expect them? So where do you expect the mediastinum to move? To stay in its position or to move?
It will go to the site of the surgery because there is lesser amount of space now available, more space available because of the lesser amount of.
So the main abnormality here that the mediastinum is normal. So the abnormality is that we have a normal mediastinum, which is wrong, right?
Exactly.
So basically, but it may be sometimes initially after the immediate nominectomy, you may not see a lot of mediastinal shift. So if you see this immediately after the surgery, you may call it normal. Okay? But definitely this patient had nominectomy many years ago. This is abnormal for two reasons. Number one, there is air within the space. After many years, you shouldn't see air in the space. And the second thing is that there is normalization of the mediastinum, which is wrong. This means that there is building up of pressure within the right hemothorax that is pushing the mediastinum to its normal position. Okay? Yes. So what could have caused this air collection in the right hemithorax?
be due to some underlying post-operative complications. Post-operative complications like some infection.
Okay. What kind of infection?
Likely due to air-producing organisms.
Excellent. Yeah, possibility. Any other possibilities?
There could be some superimposed surgical emphysema that might reflect as this air. There can be a bronchopleural fistula formation.
Excellent. So link from the bronchial stump through.
Exactly.
What else? Could it be
Thirdly,
iatrogenic from insertion of tube?
Yes, it could be. I'm basically concerned about all the post-operative causes of the air. That is iatrogenic, infectious, leaks, bronchopleural fistula formation.
Okay, so now we move to the CT scan. Okay.
Right. So I'm provided with the two images of CT chest with IP contrast, axial view. One
so
is
the patient had nominectomy just for TB, not for malignancy. Okay.
Pardon? Can you
The patient had nominectomy for tuberculosis, not for malignancy.
Okay, fine. So I can appreciate that there is a large cavitating area and there is development of an air fluid level within it. In fact, the air fluid level within it is also having specks of air in it. There is communication of this cavity due to communication with the central airway, and there is.
I'm not showing here. There was no communication with the central airway. There's no image of the central airway here. You mean here? You mean here?
Yes.
This is the esophagus.
Okay.
This is the esophagus.
Okay.
So are you saying that there is communication with the esophagus?
In the first image, the mediastinal window, if I can see on diaphragm and if I can see any, there seems to be a communication between it and the esophagus. Again, there can be an iatrogenic or abnormal communication between the resected lung and the esophagus. Fistulous communication between these two areas, and that might have caused for the infection and for the air fluid level. Basically, I'll be concerned about finding out the source of air which has found its way into this patient. That again, as I've mentioned earlier, could be due to infection, could be due to iatrogenic cause, abnormal fistulous communication. These are all reasons on which I'm thinking upon.
That all the scenarios we considered that even bronchoscopy was done. There was no bronchopleural fistula. Okay, there was no history of insertion of a tube, etc. So now any other possibility here that causes, the presence of air in the pleura? You mentioned the esophagus. Okay, do you think that could be abnormality in the esophagus?
There may be an abnormal communication with the esophagus.
So how to confirm this?
Esophagoscopy.
Or
an upper GI barium study.
So do you see any contrast leak?
Yes, the contrast leak is very evident, particularly in the lateral oblique image, in which I can appreciate a linear tunneling of the contrast emanating from the esophagus and extending anteriorly, which is signifying a fistulous tract between the site of surgery and that is the lung and the esophagus.
So what do you do next?
I'll defer the patient for surgical repair.
Yeah.
And so these are the upper GI barium study of post-surgical repair, and there is no such communication which was earlier visualized. So the the communication had been, the fistulous tract has been repaired.
And you see the mediastinum now started to shift back to normal, and there is now opacification of the right hemithorax.
Exactly.
So now the problem is being almost solved. Okay.
Exactly.
So basically, so again, this was a case of esophagopleural fistula. This is extremely rare. This is the only case I've seen in my practice. Normally, when you see air after surgery within the pleural space, most commonly it's iatrogenic, related to the insertion of pigtail catheter, etc., or pleural tapping. It might be related to gas-forming infection or due to bronchopleural fistula. In the early stage, you may see bronchopleural fistula after surgery related to infection of the stump. But in the later stages, particularly if the patient was operated for resection of a tumor, then you might consider tumor recurrence as a cause of bronchopleural fistula.
So I've been presented with a chest X-ray frontal projection of a slightly mature patient. I can see soft tissue density opacity in the right paracardiac region, which does not appear to be silhouetting the right heart border. So,
are you sure? Where's the right heart? I can't see it. This is very clear left heart border.
Yeah.
You see a clear right heart border?
I'm actually suspicious because it's not very clear, but it's also okay. So it's silhouetting the right heart border, and it has the convex right lateral margin, and the remaining lung parenchyma on the right side appears normal, and there's no soft tissue opacity in the left lung field. The retrocardiac region appears normal. The visualized bones appear normal. The CP angles are normal. So because it is also making an obtuse angle with the mediastinum, I could think of mediastinal opacity. However, the opacity does not have any calcifications. It does not have any grossly spiculated margins. It is at least more than 3 centimeters. So I would like to advise a contrast enhanced CT to confirm, or a lateral chest X-ray first, if that's available. And
I will give you lateral X-ray.
So on the lateral X-ray, I can see that the retrosternal clear space is obscured.
This is the retrosternal clear space. This is the opacity projecting over the cardiac shadow.
The opacity is definitely okay. So
here's the abnormality.
So it could be intrapulmonary.
So let's now sum up. We are dealing with an opacity which has sharp margins.
Yeah.
That is silhouetting the right heart border.
And it's the right heart border.
Projected over the location.
The heart.
The cardiac shadow.
Yeah. So it's slightly in the middle lobe.
So it is middle lobe or within the anterior mediastinum.
Yeah.
Okay. Yeah. So what's the differential diagnosis here?
So if it's in the middle lobe, I would think of a pulmonary mass and mediastinum, bronchogenic carcinoma, or a cystic mass.
Like what?
Like pleuropericardial cyst or bronchogenic cyst.
Possible.
Or
most common, you will see mediastinal mass. What else you would consider? Lymph node enlargement, right?
Yeah.
Okay. Anything else?
Anterior could be the patient could be a thymoma or a germ cell tumor.
Possible, but this is a bit low for that. It's more in the supramediastinum rather than here, more superior location, but all possible. So what are we going to do next?
I would like to advise a contrast-enhanced CT scan of the chest to confirm the morphology of the mass and see if
Unfortunately,
it takes
we don't have a contrast enhanced. We have non-enhanced study.
Okay, so these are selected axial images of plain CT taken in the soft tissue window. There is a well-defined soft tissue mass in the right paracardiac region, which is closely abutting the right heart border, and it appears to be arising from the mediastinum, and because it's forming an obtuse angle with the right heart border. I would like to confirm the density of the mass, if that's possible.
Cyst.
It's a cystic mass. So then a pleuropericardial cyst would be my top differential.
Sure. So this is incidental finding, classical appearance, classical location of a pericardial cyst. Like 90% of them will appear in the right cardiopharynx angle, 10% will develop in the left cardiopharynx angle. Extremely benign, rare, leave me alone lesion, okay? Usually you don't need to intervene with these cysts.
Okay.
It is a companion case, like in this case, there's another bigger mass that is obscuring the right heart border, okay? And it has fatty content, and there's some bowel penetrating in the anterior mediastinum area. This is Morgagni hernia, okay? So this is a companion case. In trauma patients, in a trauma patient, you see as well obliteration of the left heart border, elevation of the diaphragm. Hello? Somebody is... Hello?
Yes, sir, I'm here.
So basically you see in a trauma patient, like there's maybe the same appearance, but is on the left side. You see loss of the left heart border, elevation of the diaphragm. In a trauma patient, you see similar appearance. You have to consider traumatic diaphragmatic injury until proven otherwise, okay?
Okay,
so,
yes.
Pericardial cyst, it has a differential diagnosis, but don't forget to mention Morgagni hernia.
Okay.
And in this case, another traumatic injury to the diaphragm. This is a young patient presenting with hypertension.
Okay. I am provided with the frontal X-ray chest of skeletally matured patients. I am able to appreciate a bulky right hyla, and there is linear engorgement of the vessels, predominantly on the right side. The concavity of the hyla on the left side is also changed into convexity. Their position...
This is okay. On the left hilum, it tends to be slightly more rounded than, I mean, you will see it's a bit more rounded than the V shape. This is okay, but this is not dense and okay. And the right hilum looks, I mean, yeah, a bit prominent, but this is vascular prominence. The V shape is preserved. There is no increased density, okay?
Right, sir.
Okay.
Okay. They are normal in position hyla. The clavicles are equidistant from the trachea. Trachea is central. Heart size appears to be normal. The cardiophrenic angles and diaphragmatic angles appears to be clear. I'm just showing the apices. They appears to be normal. I'm unable to appreciate any retrocardiac density.
Okay. So is this a normal X-ray?
So far, I'm unable to detect any abnormality, sir.
So basically now you have to go to the systematic approach, right?
Right, sir.
So we start with the parenchyma. With the abdomen. Do you see anything?
Sorry to interrupt you, sir. I see inferior notching in the left lower ribs.
Yes.
And also, they are definitely there. So based on.
And what else? What do you call this?
Is that narrow cardiac aortic fillet?
Just a moment. Where's the pointer? How can I find it? Just a moment. Okay, just.
Yeah, aortic arch, sir.
So what do you call this?
It's a three shape configuration and inferior
figure of three configuration. Yes, how do you explain why do you see rib notching here?
So these are basically due to the engorgement of the intercostal vessels due to a bypass of the blood, because there is stenosis at the level of the aortic arch. So it's usually in the
not the aortic arch. It's the stenosis. Not it can happen in the aortic arch, but usually if it's in the aortic arch, you will not see bilateral rib notching. You see unilateral, depending on the location.
So it is usually preductal and postductal.
It's in the isthmus, aortic isthmus stenosis. Yeah.
Right, sir.
There's engorgement, diversion of flow into the intercostal arteries.
Yes, sir.
So what do you call this condition? Coarctation of the aorta.
Yes, so sorry, sir. Coarctation.
No problem. Coarctation of the aorta. Any other differential for rib notching? I'm sure you will find it in the Chapman or in other.
Yes, sir. It's neurofibromatosis, rheumatoid arthritis, or some bypass surgery in tetralogy of Fallot, or this can also happen in polio patients.
Sometimes even if we have chest wall hemangiomas,
right. But
you see the localized rib notching.
Yes, sir. But in vascular hemangiomas, they are more focal. They don't.
It will be focal, not diffuse like this.
Right. Yes, sir.
And in patient with SVC stenosis or occlusion with the chronic diversion of engorgement of the intercostal veins, sometimes you will see rib notching.
Yes, along with that, we will appreciate a widening of the superior mediastinum.
But in your practice, in the exams, inferior rib notching, it's coarctation of the aorta until proven otherwise.
Right, sir.
Okay. So this is the CT scan, CT angiography that we ask for usually. It's preferred to do it with ECG gating in order to assess the heart, because what is the commonest cardiac association of coarctation of the aorta? Do you know what it is?
Yes, sir. Bicuspid aortic valve.
Bicuspid aortic valve. So up to 50% of these people will have bicuspid aortic valve that can lead to cardiac problems. So the stenosis here is obvious. You see narrowing of the aorta, descending aorta, and poststenotic dilatation, leading to the figure of three configuration. And you will see how the intercostal arteries are big, and the internal mammary arteries are big as well.
Right.
Prominent, okay?
Right.
So the treatment for these patients, you have to consult the vascular surgery or our colleagues in intervention radiology. Depending on the age of the patient, they either do surgery, or nowadays they do just the stenting, which is non-invasive, okay? So either way, the treatment is we need to intervene to relieve the pressure, because otherwise the patient may have vascular complications later on. Okay?
Yes, sir.
So this is a case of coarctation of the aorta. My personal opinion, you may follow it or not, may apply to you or not. First of all, these exams are set for testing your long-term knowledge, not short-term knowledge. Okay, I will read for instance the chest, for instance, chest CT. I will check the lymph nodes. So they will say no, there is or there are no lymph nodes. And then I'll check the pleural spaces, and then the cardiac and the pericardiac space, then the chest wall, and then I'll move to the lungs. And this way, you show the examiner that you know what are doing, and in case if there's anything, you will you will detect it. Okay, even if you don't detect it, at least show the examiner that you are a safe physician.